we apologize for starting a little bit late. We were waiting on our speaker, and we are going to get started now. So good morning, depending on where you're sitting. Good afternoon, good evening, and welcome. My name is Lenias Hwenda, and I am the moderator of the webinar today. I'm the founder and CEO of Medicines for Africa. We are an independent Pan-African social enterprise with a mission to improve patient safety through safer medicines. Please allow me to welcome our eminent speaker, Dr. Martins Iluyomade, who is the Director of Investigations and Enforcement at NAFDAC. And I would like to thank the Director General also of NAFDAC, Professor Moji Adeyeye, for giving us the opportunity to learn from the excellent work that NAFDAC is doing on the front lines of fighting to protect patients from medicines that could do harm. NAFDAC is one of Africa's several NRAs that are operating at maturity level 3, which is a lot more advanced. So there is so much that we can learn from the Nigerian experience. I also want to thank our other director generals from other national regulatory authorities around the continent who have supported us in a number of ways. And in particular, I would like to mention the Director General of MCAZ, Mr. Richard Rukwata, Director General of BOMRA, of EDA, EFDA, and ZAMRA, and of course, the CEO of SAPRA here in South Africa, where we are based. We've received tremendous support from all of our leaders sitting in the national regulatory authorities, and of course, from the African Medicines Agency as well. So friends, colleagues from industry, from academia, and of course, our frontline youths who are part of the Medicines for Africa community cadre, who are working as change makers, we thank you for joining us today. Now, our mission at Medicines for Africa is really to protect patient safety from harm. And our vision is really to become the partner of choice, a consistent voice on patient safety in Africa. We are based in South Africa, and we have a Pan-African outlook addressing the challenge of unsafe medicines that are causing harm to patients all over our continent. Now, let me tell you a little bit about the frontline defenses. We have these frontline defenses against unsafe medicines in Africa, which is a webinar series. It's one of Medicines for Africa's flagship initiatives for achieving this mission of protecting patients. Now, many of us assume that we understand what unsafe medicines are, but of course, the common one that we all talk about are substandard, falsified medicines. But the scope of them is a lot broader than that. And our inaugural speaker, Dr. Iluyomade, is going to help us understand better the threats they pose and, to the well-being of patients across the entire continent. But before I do that, I'd like to take a pause here and do a very quick poll, just to give us an idea of everyone in the room. Excellent turnout, by the way. Thank you, everyone. But would like to get an idea of the baseline knowledge of the issue and where there might be need for clarification. Put a poll on the screen for you to just participate. We'll just take 20 seconds to look at this poll, and you all vote. And it's, nobody sees how you vote, so it's completely anonymous. And then we can continue. Just give me a second. I will put the poll on the screen. So, right. So 1 second. So we get it up. I hope that technology will be on my side. So do you see the poll? Do you see the question?
Yes, it's working.
It's working. Okay. So please vote on the first question. Which of the following best describes your current understanding of unsafe medicines, including substandard and falsified medicines. Okay, just a few more seconds. We're going to stop the poll in 2 seconds, and let's end it and see the answer. Let's share the results. Let's see what they look like. Do you see the results?
Yes, we can see.
Yeah, so 57% of people can clearly define unsafe medicines, including some standard. 38% are somewhat familiar, and 13% don't really fully understand them. And there's no one who's not familiar with them. So that's the end. That's at least the result. So yeah, about 50% of people who voted can clearly define the different kinds of unsafe medicines, including substandard, falsified, and degraded. 40% are somewhat unfamiliar, but not confident in distinguishing them. And 10% are aware of them, but don't really fully understand them. So great results, a mix of familiarity, which is exactly why this topic matters. So this opening webinar examines the scope of the problem and why clear terminology really matters. We are going to explore the scale of unsafe medicines in the African context, based on the Nigerian context. And what we're hoping that participants will be able to gain from this is a clearer understanding of the different ways medicines can become unsafe beyond the usual problem that we all talk about of substandard falsified medicines, and why recognizing them is really the first step towards protecting patients and also strengthening medicine systems. Now, let's talk a little bit about patient safety. I mean, our regulators are the custodians of the medicines we take. They make sure that they are safe, they work as they should. But theirs is the most difficult mission to protect patients from harm, because it's really a challenge that requires everybody to take their part, from the patients themselves, from the industry that produces those products, and frontline healthcare professionals who are helping to get those products to patients. Now, truly protecting patients really requires that we engage all of the important stakeholders, from regulators, patient groups, healthcare professionals, industry, and communities. My colleague recently said to me, patient safety in Africa is really not on the agenda yet, and we need to bring it on the agenda. Medicines for Africa is trying to do just that, through the building Africa's frontline defenses against unsafe medicines. What we'd like to see is patient safety becoming a part of everyday language in the clinic. As my friend and colleague, Professor Nilaveni at Wits University often says, not only do unsafe medicines need to be part of everyday conversations in the clinical setting, those on the front lines need to ask one particular question, relentlessly. How does what I'm doing, the decisions that I take in this moment, reduce harm to patients? Now, why talk of unsafe medicines, right? Because often the conversations we have is about substandard, counterfeited medical products. We believe at Medicines for Africa that if we truly care about keeping patients safe from harm, we need to take a broader lens beyond just the substandard medicines, the counterfeited, the falsified medical products, and look at all the other factors that affects medicine safety, diversions on all these things that can result to medicines becoming unsafe. The ones we know about and talk about is the high burden of counterfeits, of substandard medical products, but there are other factors that are rarely talked about that are equally harmful. And here, these can be degradation of products, expiry, diversions, theft, and smuggling across borders. All of these factors contribute to medical products becoming unsafe. So, what is the Frontline Defenses Initiative that Medicines for Africa is launching today? So let me just take a moment to tell you about that. Building Africa's Frontline Defenses Against Unsafe Medicines is a series of 12 webinars that are progressively going to explore the problem of unsafe medicines. It is a foundational series that is really trying to answer the question, how do we improve our understanding of these unsafe products and our ability to recognize them and be able to intervene on behalf of patients. And the first series really focuses on detection, on responses. It's really the defensive stage. How do we, at least on the front line, defend patients, keep them safe? So the series comprises of three sort of, consecutive series, which will bring expert insights that are anchored in real-world experiences, real-world case studies, like the one our speaker is going to give us today, and practical tools that those on the front lines are actually using to show us what's working and what isn't working, where are the gaps, and how do we close them. So the webinar series is going to help us to progressively build our knowledge base and skills that are needed on the front lines, on the level of individuals to help us strengthen patient safety across the continent, all over. And it's going to help us do this by building the human capacity to respond. The people on the front line, the ones that are often really left out in the conversation and in the solutions that we put forward. And then we're going to, hopefully we would leverage that individual knowledge base and capacity to build systems that can actually effectively prevent risk. And then finally, use that to refine and optimize the way we approach prevention, the way we approach responses to ensure that those systems actually work as they should in the real world. So this is a progression that should reflect a natural evolution that starts with developing frontline vigilance and action by individuals on the front lines, and then expanding to system-wide prevention and risk elimination, finally taking action to ensure systems are effective, they're adaptive, they're continuously improving. So this journey moves participants from frontline practice to system-level impact, equipping them not only to act against unsafe medicines and protecting patients when they encounter them, but to build those systems where risks are far less likely to occur and responses are consistently effective and able to protect patients. What are the expectations or our expectations of this series? The opening session is called The Hidden Crisis: Understanding Unsafe Medicines and Why They Matter. It's really going to explain the scope of unsafe medicines beyond the one that we talk the most about, highlight their scale and real-world consequences, reframing them as an urgent patient safety issue and a public health challenge that requires frontline vigilance. And by strengthening awareness and vigilance, this first session is really expected to contribute to earlier detection and reduce the likelihood of unsafe medicines ever reaching the hands of patients in the first place. So today we hope to lay the foundation for addressing the central question: how do we recognize and respond to unsafe medicines, consistently? So we are honored today to have the respected and eminent practitioner who's on the front lines of Nigeria's fight against this challenge. And he's going to really help us articulate the risks and their implications for patient safety and how they are dealing with it in Nigeria. So it is my pleasure to welcome our inaugural speaker, who is, giving the first of the series of these webinars, Building Frontlines Defenses series. Dr. Martins Iluyomade, who is the head of investigations and enforcement at NAFDAC. As the Director of Investigation and Enforcement at the National Agency for Food and Drug Administration and Control in Nigeria, Dr. Iluyomade stands at the very heart of Africa's fight to protect patients from unsafe medicines. He has more than 2 decades of frontline experience, and he has led bold, intelligence-driven operations that have dismantled major counterfeit drug networks and safeguarded countless lives. He is the chairman of the Federal Task Force on Counterfeit and Fake Drugs and Unwholesome Processed Foods, and a passionate advocate for safe medicines globally. Beyond his achievements, he has an unwavering commitment to patient safety, regulatory excellence, and public trust that really sets him apart. Not only does he bring authority, he also brings the lived experience and insights of real challenges on the ground, real decisions, and the impact those decisions are having. And so as we open this series under the theme on the front lines of patient safety, Dr. Iloyomade's voice is a fitting guide to help us to get this critical conversation started. So Dr. Iluyomade, we are delighted to have your contribution, your insights to help us start this important conversation, a series of conversations that is going to really occur over the next several weeks. Dr. Iluyomade, do we have you on the line?
Yes, please. Good afternoon, everyone. I hope you can hear me.
We can hear you well. You have the flow, sir.
Oh, great, great. It's my pleasure to be here, and I want to thank you, Message for Africa, and under the respected leadership of Lenias, for the work you are doing on the front line, also bringing patient safety to a lot of people, and bringing it to the front line in Africa. I want to congratulate also Message for Africa for starting this series, because I believe it's going to be a series that will be helpful for a lot of people, and will bring in context a lot of things that is going on the ground about patient safety with medicines that a lot of people don't know. And actually, let me start by saying that the crisis is not just only hidden; is now blown up everywhere. Because we use the word hidden crisis. Now, for example, I want to say that for the country that I speak for, it is no longer hidden. It's a crisis that is fully blown. And when I use the word fully blown, is because we cannot estimate the number of casualties that we have gotten because of use of unsafe medicines. We cannot we cannot estimate the economic losses. We cannot estimate the number of human lives that have been lost. We cannot estimate the kind of permanent damages, all of that has happened. So it's a crisis everywhere. And that is why I applaud Message for Africa for starting this series and bringing this consciousness back to everybody to see and to understand exactly what is happening. I want to start this afternoon by saying that the reality of the hidden crisis is staring all of us in the face. Unsafe medicines are not isolated incidents, and I want to say that they are not just isolated incidents that maybe it's just one person or the other. There is a problem, it's a systemic public health threat that all of us have to check. It's a systemic public health threat. It starts from, I will call it from the point of manufacture of the product to the point at which it gets to the hand of the patients. That is where all of this, everything in between it is a system. And so at every point of this system is where we have the threat. And that is why we have to look at the issue of unsafe medicines. The reality is that they are here with us, and it's a systemic problem, and it is public health problem also. They present across supply chains. We can see in different supply chains, they affect millions daily, and it's often discovered only after treatment failure. That's why it is hidden. You've seen cases of patients here in Nigeria. Nigeria is a very, I will be using Nigeria a lot because that's my turf, and that's where we have frontline experience discussing these issues. That's where we have frontline experience discussing these issues. Now, when we look at this, we see a lot of issues happening with this in the country, and many people. Let me use example malaria, because I saw in the poll you use malaria. Many people think malaria is a simple treatment thing that can be done. Somebody should just take a malaria treatment and will be okay. And the next thing you see is that you see treatment failures, people using anti-malarials not working, people not getting anything, and then they keep, I just treated malaria. And 2 weeks after, you are back in the hospital with the same thing, and people are wondering what's happening. And that's why we say that most times the reality is that people know it after treatment failure, and who knows, only God knows how many lives have been lost unnecessarily because of these issues that we have. What are unsafe medicines? I think it's good for me to also now go to the slides. What are unsafe medicine? And let's do some definition here for all of us to see. I'm on reality. Yes, thank you.
Okay.
So I've finished. I've discussed that we often discover this after the treatment failure, and that's when most of us see what has happened. That's when somebody has treated himself and is not getting well, and that's where the patient safety should be at the heart of the conversations that we have in Africa. And I'm happy with what Medicines for Africa is doing concerning that. Patient safety to be in the heart of the conversations, because at the end of the day, it's the patient that bears the brunt of unsafe medicines. It's the patients that bear the brunt, and is already somebody who is already sick that needs help, going through another problem where you have to use your money again to buy medicines that will not work. Is a double jeopardy for me, and that's why we do what we do with all the passion that we have. Why are unsafe? What are unsafe medicines? And that's the next slide I want to see. What are unsafe medicines? Let's look at this. Let's look at some definitions. Okay. What are unsafe medicines? You can move the slide. What are unsafe medicines? Now, I heard Lenias mentioning what we are talking about here, falsified substandard, but I want to go beyond this actually falsified substandard products, to go into falsely labeled, to spurious, and then mention or registered. Let me give it. I like to give a lot of frontline experiences here. Sometimes in 2011, as a younger officer, I was in the port at that time, and a set of containers of medicine came in, anti-malaria at that time, and they were declared as sellatives. And why they were declared as sellatives is such that they can evade checks by regulatory authorities, checks by NAFDAC, and lab tests, and all of that. They were falsely labeled as sellatives. But we had intelligence that gave us, we have intelligence about the medicines, about the container, that this container is actually carrying medicines and not sellatives as described. So we intercepted it. I led the team that intercepted it. And immediately we opened the first line of those things. We saw sellatives, but inside we saw a lot of anti-malarials that around that time were no longer being produced for the Nigerian market. And we did a test of those things, nothing was inside. I can tell you zero active, zero. There was no single active ingredient inside it, and that was a lot of issue. Of course, we arrested the owner of the consignment, and the country where it was coming from, China. We contacted them through Interpol, and they were able to arrest the shipper, and they dealt with it in their own way. And then spurious. What another thing that is now a major issue now in Africa that we all have to check are spurious medicines. And what are spurious? People bringing in medicines that, number one, nobody knows anything about it, no active, no work has been done, no record. You get a lot of people making a lot of claims about these medicines, and people, because we're in the age of internet now, people advertise them on the internet, and everybody just, okay, they said this thing is working for this, and without a single major test that has been done, and people take these medicines and it doesn't work. The patients suffer a brunt for it. We also have unregistered medicines. But for us in Nigeria, I don't know what happens in other African countries. We have a law. Any medicine coming into this country has to be registered with NAFDAC. So that way we're able to check the medicines. If you come in, it's documented. For every shipment that comes in, we do our lab test, we confirm it's okay before we release to the public. So any kind of unregistered medicine that you see in the system has not gone through all these checks. And these are part of the problems that we see. So we see a lot of you try to bypass the system to smuggle in unregistered products into the system. And so I said this, the key point here, a medicine doesn't have to be counterfeit for it to be unsafe. We have so much things that could happen in the supply chain that could make a medicine unsafe. A medicine could actually be, as we'll see in the next slide that we'll see, a medicine could actually be genuine from the manufacturer, but by the time it's getting to the patient, it's already unsafe because of so many things that happen along the distribution line and the chain. And all of these things we have to take into consideration, because if we don't do it, is the end users, which are the patients, that will suffer the brunt. So please move to the next slide, the hidden problem. So let's go to the hidden problem. One of the issues of the hidden problem is not just manufacturing. That's what I was talking about. It is storage. And I'll be sharing experiences on the front line with these issues of storage. It is distribution, it is handling. So even a quality medicine can become ineffective before reaching the patient, which is part of the things that I'll be discussing in the frontline stage. Let's look at the case study of Onitsha open drug market operation, which is, I believe, is the largest open drug market operation that has been carried out in Africa so far. We were able to do 3 major open markets in Nigeria. Those are the places where you have the largest this and now. Each of those stores in those places are over 5,000 stores. Each of these places have 5,000 stores and warehouses. Each of these markets I mentioned, 3 of them we did simultaneously, and each of them have over 5,000 to 6,000 stores, warehouses, distribution points that we have to screen at the same time. So I go to the case study of Onitsha open drug market operation, and let us see some of the things we found out there. The problems we discovered, next slide. The problem we discovered at the bridgehead market on Onitsha. One, we saw a lot of, next slide, unlicensed medicines for distribution. We saw it that people are distributing on unlicensed medicines. We saw a lot of people who are not professionals handling medicines. We saw there's no structure there for regulatory compliance. It is chaotic, it is unregulated distribution system. And this is a major problem. As you can see in the picture there beside that slide, these pictures are live pictures that we took from the field. So some of the messes are actually packed like this, like you can see them. Some of them are hidden in sacks, so that people don't even know what it is. Now, these are how some of them brought them in, and because of the clandestine nature of what they want to do, they put this thing like this, wrap it, and so you won't even know it's messing there until somebody needs it, and they'll go inside and go and bring it up. So this can only be done by unprofessionals. You can only have this level of crude way of distributing medicine by people who do not value medicine, who just see medicine as an article of trade and not something about patient safety and all of that. So this definitely is one of the things we found out there. Let me go to the next slide, the critical findings because of my time. One, we saw a lot of controlled medicines like pentazocine, Schedule 1 and Schedule 2 narcotics in open circulation. And we know that these medicines are supposed to be handled by professionals, under the supervision of professionals, even before they are dispensed. But where the people we saw, most of them just maybe apprentices and all of that, are the people handling these kind of sensitive medicines. Definitely, there's no way they can handle it well because they really don't even know the value in the first place, other than the source of income for them. And the second thing we noticed there is that the stores, I told you, each of those places are over 6,000. Each store has over 6,000. Each market has over 6,000 stores. What we noticed there is that there are no ventilations in those stores. High heat, high humidity, medicine stored with chemicals and food and other things. So definitely, this is a direct violation of good distribution practice, and is a clear violation. So any medicine you see in this kind of condition, even though they are genuine from the manufacturer, can never get to the end user the way they were made. No longer, you cannot vouch for the integrity of the medicine anymore, as at the time they get to the end user, which are the patients. Let's look at the actions that we took. Actions taken. Next slide. Over 130 trailers. Action taken. Next slide. Over 130 trailers of this kind of medicines were evacuated. So you can see, I took this picture in the Frontline, who is where we're moving these things out of the market. This quantity we're moving out, and over 130 of these were moved out of the market. We did a mass destruction of unsafe medicines, and then we prosecuted offenders. I know a lot of people ask what happened to the offenders. The prosecution is, as I speak to you, the prosecution is still ongoing, and we're getting that done with. And then, but we didn't stop there. We also did some stakeholder sensitization and engagement we had with them, because one of the things I didn't put in this slide was that we had to sign an undertaking, and it's very good that we note that we signed an undertaking with them to leave that place. That medicines can only be sold in the open space like that, to a government-regulated place where there will be presence of NAFDAC there will be presence of PCN, there will be presence of regulatory agencies and law enforcement agencies. And so that kind of store will be the central store where every medicine coming to the state will come to. And so whatever is going out, everybody will know what is going out to other distributors. And that's the kind of agreement we sign and undertaking for different times for them to move from where they are currently to that place. And there, nobody who is not a professional will be allowed to handle medicines and all of that. So we try to solve the problem that we met in the open drug market in Onitsha. So let's see what does this mean for people. That's the next slide. Under poor conditions, you know that active pharmaceutical APIs, they degrade. All of us know that. Chemical stability is compromised, potency reduces, bioavailability becomes unpredictable, and these are the things that we see under this kind of conditions, and this that's the implication of this. So let's look at why does this matter. Next slide. Why does this matter? Now, this leads to the impact on patients, which is the major part that we are talking about here. I was very happy when Lenias was talking about, let us talk about the patient, let's put in the front line, and that's a very important thing. So let's look at the patient impact of this. Treatment failure, we see that everywhere. Disease progression, increased mortality rate, subtherapeutic dosing, we all know all this. We have toxicity risk because of degradation of some medicines that they get toxic when they are degraded and all of that. So because of heat and all of that, these impacts are huge on patients, and WHO estimates that 10% of medicines in low and middle income countries are substandard and falsified. That's a general poll that WHO gave. But beyond just that, along the distribution chain, we could have all of these impacts on patients, even though not intended. But we have to speak out about it, because you can have the best of intentions, have the best of medicines, and the way they are handled along the distribution chain is a problem. So you see a problem to the patient, because at the end of the day, as long as the patient is not getting the right medicine at the right dose at the right time, you see the problem. And so we have to, and that's why this impact on patients is very important. So let's also look at public health impact. The next slide. For the public health impact, we see here, we've been talking about AMRs. That's part of the public health impact we're going to see. Antimicrobial resistance, reduced effectiveness of first-line therapies. We see increased burden on already stretched health systems. Something that should not be treated once and somebody goes so that they can have space for other people. You see people trooping the hospital and looking for more and more treatment where they should have been discharged and all of that. So you are creating more burden on the already stretched health systems in the society. And we also have maternal and child health. That's part of the impact that we see. And that's next slide. Maternal and child health is compromised. We have compromised medicines that affect pregnancy and childbirth, and that's a serious issue. The DG used to mention, my DG used to mention is a story where somebody was giving oxytocin, a child she was delivering and all of that, and the thing failed. And it is because of some of this. We did investigation. I know I led an investigation into some oxytocin stuff about 2-3 years back, and we traced the oxytocin to the manufacturer. And with the test we did with the manufacturer and all of that, the oxytocin that left the facility was okay, 100%. But the oxytocin we met in the market are degraded. What is left inside there is now up to 60%. And so this has impact on maternal and child health. And you can imagine how many women have lost their lives unnecessarily based on this, just alone. And beyond just here, we can also look at the economic impact. Next slide, economic impact. Patients pay multiple times for ineffective treatment, and that's the problem. Patient pays multiple times for ineffective treatment, increased hospital visits, and prolonged illness. We have loss of productivity and income. Over 30 billion global economic burden from substandard and falsified medicines is what we see here. So that's the kind of economic impact that we are seeing. Okay, so let's address the root causes. If you know all the problem, you know the this, you have to look what are the root cause. And that's the next slide. Let me quickly talk about the root cause before we close. Root cause one, economic problems. And what do I mean by economic problems? In Africa, a lot of people prefer cheaper alternatives. If something costs 10 naira, let me just use Nigerian listing, and another person will want to, okay, so can I get it less? So most of the decisions that a lot of people take on medicines, on everything, but especially also on medicine, is economic decision. How much can you afford? How can you get it? And this has to do with our economic situation and the income of the people involved. So that makes this strife. So people will always look for alternatives for this so that you look for a cheaper alternative. And this is one of the major drivers of substandard, falsified, or spurious medicine in circulation that we need to address. The second one is weak enforcement. I gave the example I gave the other time. That thing went through the example I gave the other time is weak enforcement, where either inadequate staffing, logistics, intelligence, or even the law around this that will make people that will be a deterrent for other people. So if all of these are not taken care of, it will be a fertile ground for people to begin to beat the system around and try and get the best they can make out of the system at the extent of the patient. Informal supply chains. These are root causes. You have informal supply chains where anything can enter the supply chain. So you have informal supply chain where things can just enter the supply chain without checks. And that's, you see, these are the root causes that you will see. Poor compliance culture. Yes, even when you correct some people and all of that, we have compliance issues. Most people still want to do what they think is they want to do, and not what is right that should be done. Now, this last point I want to explain it: confusing regulatory laws and processes. And what I mean by that is that even some people want to genuinely, okay, so let me subject myself to test and to regulatory this thing. All of us regulatory agencies should make sure that the laws and the processes are easy to understand and not confusing and not exactly pushing people away in all of this, because some people, I understand that some people just want to get away from regulatory agencies because they believe the laws are too much, they are cumbersome, they cannot really understand it and all of that. But we have to make it more friendly. I'm not saying we should lessen the standard, or we should make it more friendly for people to be able to easily follow the laws and abide by the rules of the game. Let me quickly go to the next slide. What must change? What must change in Africa, I believe, for us to move faster and address this issue? One, we have to improve the economy. That's increase the purchasing power of people so that people don't look for cheaper alternatives all the time. The second thing is that we have to make laws, regulations, and processes easily relatable to citizens. That's the second thing we have to do. Well, let's make our laws, processes easily relatable to citizens. The third one, we have to reduce incentives and enforce severe consequences for offenders. That's strengthening the enforcement now. And we have to improve surveillance and pharmacovigilance That area has to be strengthened. There should be a process in place where I know that a lot of countries, including Nigeria, we have pharmacovigilance systems where people report ADRs, people report all of these events and all of the adverse events and adverse reactions. I think we need more of that so that we have a system where we monitor what goes wrong before it begins to spread. And I remember I think over a year ago, we had a situation in Nigeria where somebody was taking a particular antibiotics and a particular hospital started reporting that this is like third, fifth patient that after taking this, there are adverse events. And NAFDAC had to swing into action. And we discovered we got to the root cause of it. But if there is no strong pharmacovigilance system, we will not be able to get that done. We have to strengthen GDP and GSP compliance. And this is what we're doing. That's why we give these people condition. Like you have to move to a place where we can check what you are producing. I mean, what you are selling, the condition of the area where you are doing the good distribution practice. That is very important. We have to strengthen that. Control access to narcotics. I know most countries have control access to narcotics, but I think we need to strengthen it. In Nigeria, which I will speak about, I think we need to strengthen that more seriously because people can get narcotics over the counter, OTC, and that's wrong. People who are not licensed to hold things are holding it, and it's causing a major crisis for us. We have to enforce licensed distribution channels. That's part of what I'm talking about. We have to just enforce it that it's only licensed channels that can distribute, so that it can make enforcement easier, and then the people be made to account for what they do. We also do. It's not just about punishment. We also do public awareness, get people to understand why this matter of safe medicines. Well, get people to understand why this matter and why everybody has to be involved in it. It's not just only for regulators, it's everybody's problem that we have to look at because it's a burden for all of us. In closing, as the last, my last slide, unsafe medicines are not just product problem, they are a system failure. Protecting medicine quality is equal to protecting lives. Thank you so much. God bless you. I'm ready for questions. I'm done with my slide. Thank you so much.
Thank you, Dr. Iluyomade. That was a very illuminating presentation, when you took us through some of the things that you are doing, highlighting with the Onisha case study. I mean, for me, it's really quite striking, one thing, like maybe two things, very striking that I took away amongst the many things that you said is that a medicine doesn't have to be counterfeit in order to be unsafe. It's a very interesting point because at Medicines for Africa, we have this youth group that is trying to that has a contingent of youth activists, agents of change that are all over Africa. And we had our meeting last week. And one of the questions that one of these young people asked was, but is it true what I heard that if a medicine is registered, it's always safe? So, I mean, that point really resonated because this it really spoke to that. So thank you. And linking to that, the point that a medicine can become ineffective before reaching the patient, not necessarily because it's counterfeited or it's been falsified. And so I think these are things that sometimes we take for granted that people know, but not necessarily. So let me just encourage everyone to put your questions in the chat. And I think Lydia and others are going to be helping us to to collect that. Someone had their hand up and they put it down. Can you come in? Whoever had your hand up, I see that your hand has gone down.
It's
okay.
Mujahid Ismail.
Mujahid, yes. Please go ahead. You can put on your camera and ask your question.
Okay.
Sorry, there was someone before Mujahid. Can you help me, keep track and take note of people so that, we can actually call on people. There was a lady speaking and then Mujahid. Can you go, please? Okay. We'll take Mujahid's question. Okay.
Can you open the Q&A section? And as well, my question is about, thank you very much, Prof, for that.
Can you just introduce yourself first so we know who's speaking and then you ask your question?
Yes, my name is Esther Nakazi.
Mm-hmm.
I'm a journalist in Uganda, and I appreciate the talk. It was very insightful. And I would like to understand from Prof, we have medicines like inhalers that are used for respiratory diseases that are quite expensive, and some are cheap. But we know that some policies are trying to make these inhalers align with the climate policies or climate commitments that we made. And I would like to understand, in Nigeria, what are the issues around such medicines for respiratory diseases where you have to buy or approve expensive medicines or medicines that are aligned to a certain commitment, like for climate change or climate commitments that are affordable but also give off low emissions in terms of use? Thank you very much.
Okay, we'll let Dr. Iluyomade maybe answer that question, and after this we'll take Mujahid and then Ewale 4. You can come after Mujahid. Please go ahead.
Okay, thank you. You're talking about climate change and expensive inhalers in Uganda. What we have here in Nigeria, our own experience is that there are a lot of options that you have for a particular for inhalers. Let me specify. Let me state with that. We have a lot of options. There are expensive ones, very expensive ones from multinationals, and there are and also from innovator brands. And we also have some who are generic. So the generic ones not naturally are cheaper and all of that. So our patients have options of a lot of this thing to pick from. And if it's for emission and all of that, that made the thing expensive. So we here have registered a lot of generic products that also will do the same work, and that people don't have to necessarily buy the innovator brand, and they will still give you the kind of results that you want. I hope that answers your questions. We have options here in Nigeria for that.
Thank you, Dr. Iluyomade. Mujahid, you can ask your question, please.
Okay. Good afternoon, ma.
Good afternoon, sir.
Okay. Doctor, it is my pleasure to be here with you again. We have already been on the linking. So my special thanks goes to Doctor for all the wonderful presentation. And this presentation is highly commendable as we are moving fast in Nigeria to fight against counterfeit drugs and falsified and substandard medicine. This wonderful presentation will ginger the young ones, not only Nigerians, but the whole Africa, to see that what are they going to be participate in the tackles of those falsified and substandard medicine. And for instance, now in Nigeria, I think you see that the issue that we are having in the country, as doctor, you know, is that 70% of the people that are handling wholesale and distribution of pharmaceutical products and other healthcare commodities, you see that they are not licensed professions. They are not even a pharmacist or healthcare provider. They are just inherited the business since, and now they are doing the business. So that are part of the things that contribute much more high substandard and prescribed medicine that are circulating within the communities. And to fight against that, we need to continue as now that I see that PCN were trying to gather a coordinated wholesale center so that to reduce the tackles of that falsified medicines and other health commodity. So with the help of all that states to engage in that coordinated wholesale center, I think it will help us to fight against that substandard and falsified medicine because all vendors were in one place and all vendors before they were get into that coordinated health center, they must be verified. There must need for a licensed superintendent pharmacies and other regulatory agency, as for example in Kano State, there are coordinated wholesale center. You see that
Yes.
there is NAFDAC office, PCN office, NDLEA office, and other regulatory agency. So that would help to even people that are trying to standard to almost be able that maybe they want to catch it to the coordinate person. But at the drugs
Sorry to interrupt. Are you asking a question or because we'd like to get through other questions as well? So
I'm coming to the question to Dr.
All right, I'll give you 20 seconds to ask your question before we move on.
Okay. So Doctor, with that, I think what NAFDAC are going to do now to start the partner with local healthcare profession to tackle that and to highlight people on the essence of getting right medication from the right source and supplies. That's my question.
Okay. What is NAFDAC doing to partner with healthcare professionals to solve this problem? Dr. Iluyomade.
Okay, thank you so much. NAFDAC is doing a lot. One of the first thing is sensitization. Sensitization is key. We've had a lot of sensitization meetings with healthcare professionals, telling them about distribution systems and where to get their products. In fact, during that lockdown in Onitsha, that really helped us discover some things. That it is actually possible that people can get their products directly from the approved warehouses other than in the market. Because at the beginning, people were thinking, oh, I got a lot of calls that people reach out to me during the lockdown because we locked the place down for a month. Hospitals will run out of medicines and all that. And I said, no, it's not possible because each person that is licensed to sell these medicines have their own individual warehouses and they have their own distribution systems. Let them activate that system. And I know a lot of people that came and thanked us for what we did that time because they were able to activate their own system to reach out directly to the professionals. It's quite disheartening that a lot of professionals will depend on non-professionals for medicines. To me, it's quite disheartening. And so we're doing a lot of sensitization on that to make sure that people have access to medicines only from the right sources. So that's my answer to Mujahid there. Thank you. You understand what's going on and the kind of fight we've been doing and about the coordination of hosting centers. Thank you so much. So we are also doing a lot of education to let people know that you don't have to buy medicines in the market. You can get directly from the resources. Thank you.
Thank you, Dr. Iluyomade. I think that sensitization part is it's really a big part of maybe the missing link in terms of
Yes.
the fight of of
Yes.
this challenge.
Yes.
Ewale
Yes.
4, you can take the floor and ask your question. Ewale 4, that's you. I hope I'm saying your name correctly, and maybe you're not recognizing your name because I'm mispronouncing it. What's your question?
Sorry, I've just requested that you unmute yourself. We cannot hear you. Thank you.
I think his picture seems to be frozen. Okay. Whilst we wait for Ewale, Dr. Iluyomade, can you just expand on, maybe I have a related question to the one that's just been asked by Mujahid about the intelligence-based sort of response that you've been running in Nigeria. I hear many of your peers say, well, it seems to be really working from other NRIs. Can you just maybe explain to us how that works, the intelligence-based system, how it is connecting to everything that you're doing and how that's contributing to the successes that you have seen and, that are very well documented?
Oh, thank you so much. The current administration invested a lot in intelligence gathering. And one of the things that that was initiated by Professor Moji when she came in, I have to give out this or that credence, was post-marketing surveillance. Now, PMS. So what we do in post-marketing surveillance that helps our intelligence gathering is we do mystery shopping. We go around different places, just pick medicines, we pay for it, we get receipts, and then we go ahead to make sure, and then we go ahead to make sure that we send them to lab. We have discovered a lot through that process, and that's where we're able to see the difference between what actually is in circulation and what people declare when they came in. And we've been able to use that to trace a lot of where the problems came from. So post-market surveillance is one of the major intelligence things that we are using. Then two, we also are using collaborative efforts from source countries where many of these things are coming from. For example, NAFDAC has labs in those places outside. So before anything is shipped to us, to the country, the labs will send us the result before the shipment. And that's a kind of agreement we have. And so we've been able to detect a lot also through that process, that before the shipments even arrive here in Nigeria, we already have seen the lab results and we can actually turn it back or do further regulatory process on it before coming in. Then the other thing is the third one is we have synergy with other law enforcement agencies in the country. We signed a very major MOU with Nigerian Customs. Those are the people at the front lines. First thing coming in, we have an MOU with them, and they have been able to report a lot to us of what they see and all of that. In fact, recently, as I speak, we jointly destroyed over 80 containers. That's with customs. We jointly destroyed over 80 containers of unregistered medicines falsified, fake, and all manners, even narcotics that are above the distance. So we did intelligence, we did collaborative efforts, MOU, with other intelligence agencies in the country. So these are just three of the way we are gathering intelligence, and that is helping us to achieve what we are achieving right now.
Yes, I think, the point you make about collaboration with the source countries, that's a really important one that we often wonder about, when you think about the challenges that India has with with manufacturers who are not getting the right inspections, or they are inspected, they have anomalies, but they're still allowed to produce. And we've often wondered, what should African regulators, what kind of agreements should they be having with the Indian regulatory authority to make sure that these people who are deliberately making medicines that are really not fit for purpose are not allowed to be shipping those medicines in the first place. So that's a really interesting and very important intervention, where receiving countries should have agreements with source countries where the medicines are coming from, and collaborating to prevent those medicines reaching the hands of patients in the first place. Okay, we'll take a question from Yaz, and then Tafik, followed by Salah.
Hi, can you hear me?
Yes.
Hi, Dr. Martin. Thank you very much for such an insightful presentation regarding this global issue. My question is, as a regulator, what legal, institutional, and technical changes would be required to manage falsified and substandard medicines as a real-time global public health security threat, rather than a fragmented regulatory issue? Thank you.
Please, can you take the question once again? I'm trying to.
My question was, can you hear me?
Yes, I can hear you.
Yes, what legal, institutional, or technical changes would be required to manage falsified and substandard medicines as a real-time global public health security threat, rather than a fragmented regulatory issue? And I'm asking this as a regulator.
Okay, thank you. Thank you for that very good question. If we are looking at the global institutional changes that need to be made to address this, I think one of the first things we should talk about, the NRAs globally should be talking. NRAs should be talking. There should be more. There should be more. There should be more. There should be more collaboration between NRAs. Like what institution I would have preferred is the best to happen is that anything leaving one NRA to another NRA, the receiving NRA should communicate. There should be a way of communication and getting feedbacks. That's the global thing. I think we should do more. We should do more of collaboration. The second thing I think will be another institutional change that should be done is that we need one major, all of us should have a simple criteria of measurement, where whatever NRA has approved, NRA B would have a way, and I know that is ongoing already, and I'm just speaking so that it can be better coordinated. First of all, because it's a global question you're asking, and that is being addressed through PICS. But I know that it's not all NRAs have gotten to maturity level 3, 4, and all of that where this happens. But I think that before, I don't know how this will work, but I think that we should have, even if other NRAs have not gotten to the same maturity level, ML3, ML4, ML2, there should be a common minimum way of having joint inspections and peaks where we have minimum acceptable standard. This is living here, is living here. This is minimum acceptable standard across board. And those are additional changes I think should be practical, because this issue of all NRAs working in silos will not help us. Thank you.
Thank you, Dr. Iluyomade. I will bring in Carol. Ewale 4, we know that you weren't able to ask your question before, and Tofik, you're still waiting. So we're coming to you in a minute, but I want to bring in another regulator in the room, Carol Samatanga, who is sitting at MCAZ, in case she has something to add to this question. And I think, you know, it kind of, the question that Yaz just asked touches on another question that she indicated earlier, or someone indicated earlier, that if these unsafe medicines, in particular falsified and substandard medicines, were to be treated as a global public health emergency, so we say this is urgent, not just in Africa, but everywhere, rather than just like a singular regulatory issue, what would we be doing differently, or what are we doing that aren't we doing that would happen as a result of changing that perspective, that this is just not a big problem affecting mostly Africa and African countries, but everyone. So Carol, please come in. I know maybe you have a comment, and please, you have the floor.
Yes, thank you very much. Let me thank my colleague for the nice presentation you gave. It's such an interesting topic to talk about. What is common with us is that we have gone through a rigorous process as regulators to be confirmed as mature regulators, meaning that we have systems in place to control under market surveillance and control our import and exports, which is the formal market. And I think the new dimension I just wanted for us to discuss is that we have a situation where we have the formal sector and the informal sector. So I was quite excited to learn from you, because the informal sector you mentioned in your what to do as you were closing out, that the economy is contributing a big factor in terms of, in as much as we go through the assessments, registrations, marketing authorization, that's probably going to the formal sector. But again, the main problem with what we are discussing right now would probably come from the informal sector, which market control and surveillance would then have to take care of for the greater part. So collaboration, reliance, working together would work, but in the formal sector. In the informal sector, we will still be inundated with illegal imports. And you mentioned where you're working with the police, with the customs and all, to control the importation and illegal sales off the streets and informal markets. So I was interested to know that to what extent is this problem in Nigeria? Is this what you have addressed? Because if we talk about field detection, I still feel like we're in the formal sector. But in the informal sector, where the greatest problem is. Now, if you say the economy is an issue, it means that the poorest are the most affected with this problem we're talking about. The rich people definitely buy from pharmacies, the formal sector. The greatest problem it sort of now distinguishes the type of people we are dealing with, because the economy will affect where you are going to buy. It's a push factor, because where we put standards to meet the highest standards, that's in the formal sector, everybody gets good quality products, and they tend to be a little bit more expensive. But the informal sector is coming in to fill in a gap that is probably created by regulation and meeting standards and all that, such that there is a population that is targeted by this. So I just wanted you to comment and weigh in on that.
And if I might add to Carol's point, I mean, it's a really fascinating challenge, because it seems that the point that I'm hearing is that we have solutions that work well in the formal sector, but do we have, answers for the same challenge that we are facing in the informal sector, right? But having said that, I have been to some hospitals where they say, we have to double and triple the dose of treatments, and still we see no effect, and kids are dying, kids with childhood cancer, for instance. We don't know what to do. We are at a loss. So the problem is also, I mean, it's that we have solutions that work for the formal sector, but we are still seeing big problems there as well. So what do we need to do differently to close that gap? These are like big teaching hospitals reporting these kinds of issues of medicines not having any effect, medicines that should have been tested, and they are coming through the legal formal channels that should work or assume to work.
Okay.
Yes.
Thank you, Lena. Let me start with the question with let me start with the questions from the formal and the informal sector that was raised. I agree with you that if we do collaboration and all of that, it works with formal sector, but it won't work with informal sector. And I raised the issue of economy, and as part of the things why I give you an example. I have a situation where somebody, and this is real, where somebody asked for a medicine, and he said, this one is XYZ, this is the price of XYZ, the other one is lower price. But this other one that is lower price is not the original. And the patient asked, will he work? Just do some work, just give me. This is where it was presented side by side. I've seen cases where it's presented side. So this is not a case of where somebody doesn't know. So we have cases like that. That one is basically economy that handles that kind of a thing. Purchasing power of people and all of that. We know there are 3 pillars of medicine. As a pharmacist, we're taught your medicine will not, apart from being efficacious, apart from being safe, it has to also be affordable. Because if you have medicines that people cannot afford, then you are still not reaching the patients. And that's where that comes in. But in regulating the informal sector, one of the ways is the collaboration with the first thing is collaboration with the other regulatory agencies, enforcement agencies, because this one is not something that one particular agency can handle, because they are ubiquitous, they are everywhere. So the first thing is to prevent them. That's the frontline action. The first is to prevent them from coming in the first instance. And so if you prevent them from coming in, you have reduced the problem by more than 50%. And the one that gets in mistakenly is another one you know how to deal with from the distribution channel that we are trying to talk about regulating. So if we have a watertight distribution channel, I was in a country, I think I was in Egypt sometimes ago, and I was discussing with their regulators there, and they told me if any batch of a medicine gets into the country or is manufactured within the country, they can at any point in time tell me where that batch is. So that means they have very strong traceability system and all of that. So if we have a good distribution practice, it will take care of also the what we are talking about, that's what I call it now, the unregulated, the low CADA, the informal sector. Let me just use that one. So we have a system that prevents them from even entering into the normal distribution channel in the first instance. That's another thing. Now the third one to mention is like what you mentioned about the hospital where they double the dose, they multiply the dose, and they are not getting any results. That don't forget that I mentioned something at the beginning, that the fact that the medicine is genuine from the beginning doesn't mean that by the time it's getting to the patient, it's still maintaining that thing. So they need to check also the source of the medicine, not source as in whether it's fake or substandard or all that. What has happened throughout the lifespan of that medicine, from handling, from where was it stored, how was it stored, and who are the people who have handled it. This is also very important for a tertiary institution like that. I am sure that they should have sure direct sources where they pick these messages, direct sources. They shouldn't be buying from third parties. They shouldn't be buying from. But let me be very frank here. Let me be very frank. There are a lot of sharp practices also in the hospitals. I've gone to hospitals where the owners to increase their profit and all of that, we deliberately go for a lower, less expensive product. Sometimes it might not be to the knowledge of the administrators and all of that. So they have to put the system in place to make sure that the right people are the ones supplying them. I think that will solve that issue because I don't expect the tertiary institution to buy from some places, but it happens. This is Africa. We see some of these things happen, and the fact that is genuine doesn't mean that there couldn't be anything that happened. Like example I gave during my presentation, that something could have happened along the way.
Yeah, so just because you're in the formal sector does not always necessarily protect you or ensure that what the product you're getting is safe or good quality. Yes, thank you. Ewale 4, we couldn't hear you last time. We're going to come back to you, and then we're going to go to Tawfiq. You'll have the floor.
Good evening, everyone. I am Ewale Fasibo, and I am a medical researcher. Firstly, I will have to say thank you to Lenias for bringing everyone together to forge a better medical system for our beloved African continent. To Dr. Iluyomade, I say thank you for your flawless presentation. You were very explicit, and everything synced in. My question for you, I have two questions.
The community will say, no, this is for us. We're not doing that. I had an experience with that.
Okay. Can you hear me, please?
Yes,
we can
please,
hear you.
Okay. I have two questions. Although I have more than two, but for time's sake, I will just reduce it to two.
Okay.
And make them short, eh?
Yes. I try to pack them together. How can we better integrate medicine safety into existing maternal, child, or malaria prevention campaigns rather than treating it as a standalone issue? That is my question one. Then the second one is, if you had a magic wand to strengthen one part of the prevention chain, when we talk about procurement, regulation, or community awareness, which would you choose, and what would be your reason for making your choice? Thank you.
I'm going to take these questions in groups. I'll let Dr. Iluyomade think about that question, and I'll bring in Taufik. We'll take your question too.
Okay, no problem. Okay, I tap out mine.
Thank you. My name is Taufik Saaduddin. I am a co-founder of Naftania. We are a technology company for helping anti-counterfeiting. As we are industry practitioners and do research and technology and product development, I have a couple of questions. I appreciate if we can find answer for them. First question is regarding the technology. I know there are many technologies out there and we're building our own as well. My question is, what would be an ideal technology? What's missing in current technologies for identifying illicit or counterfeit medical products? And if there is an ideal technology, how it would look like? This is the first question. Second question, we are all aware that patient awareness, consumer awareness is the real bottleneck currently, is the real bottleneck of success of preventing taking illicit products or counterfeit medicine. So if we found a technology that prevents or makes this not a prerequisite anymore, so whether the consumer or the patient is aware or unaware, either way, we can protect them from using the counterfeit products. How this would be important? So, let me rephrase this statement again. If we make the consumer or patient awareness not relevant anymore, and always he cannot take his drug or medicine except if it's original and authentic, how this would be good or important from your perspective and understanding.
Okay,
third question.
Taufik, can I stop you at 2, please? We are running out of time and we have another. So we'll stop at 2. If we have more time, we'll come back to your question. Salar, we'll take your question.
How are you? Good morning and good evening, everyone. I just want to ask about your opinion in the definitions of WHO, because most of the NRAs are aware of the definition of WHO for substandard and falsified medical products. The definition of substandard by not being aware of the intention or the negligence in the following the GMP requirements, because what we have seen in the past 2 years about the DEG and EG contamination of the products, and some of the safety alerts that have been issued by the WHO, some of them was describing the case as being a substandard, and in some cases it's been described as a falsified. Is it important to make a revisit for the definition of substandard medical product and put in our consideration the negligence or the intention in not following the GMP? Also, is it time for us to try to differentiate between the two pathways, the substandard medical products and the falsified? Because as an NRA, it's for some NRAs it's a little bit misleading. It's two different pathways that needs different activities to be dealing with this problem. And one of the points that have been raised that could it be done by one activity or by one institution? What we are facing is it is a crime. So the crime needs a lot of pillars to act to try to solve this problem. And my last thing that I want to ask about that, I think we have a lot of regulators, and most of us as a regulator, we are looking at the combating falsified medical product by following the prevention, detection, responding strategy by WHO. But what we are not investing our time in is the how to have activities that we can do for the affordability, accountability, and availability to try to eliminate the reason from why the falsified medical product is raising, which I think it will be better than prevention, because when you are making an evaluation for a country, if he is making a detection more, so he is a less advanced. When he is going to the pillar of prevention, he is more advanced. But if you are going to the affordability, availability, and accountability, you will terminate the root cause according to which the falsified medical product will rise. And thanks.
Thank you. We stop there. Dr. Iluyomade, is there any one of these you want to take first?
Yes. Let me start with the first person. Question on yes, how to build medicine safety into maternal
and child health,
child care and malaria.
Yes.
But I think these two are two sensitive areas that we looked at. One of the things we've done in Nigeria, let me use that example, and I see ongoing now, is that what was for every anti-malaria in the country, we have, and this will go into some of the things that Tawfiq was trying to say. So every anti-malaria in Nigeria will have what is called a mass authentication scratch on it for every anti-malaria, and that thing is done for medicine safety. We have that just for set of very sensitive products, and that's to answer your question on how do we build medicine safety into that. And I think that is also being done for maternal and child medicines. So that's one of the ways we have built medicine safety into that, so that anyone that you see, you have to do the scratch card before you use it and be sure that this will work. But that in itself, it can give you the genuineness of the product, right? It can give you the, but it cannot guarantee that the handling has been okay from the beginning to the end. So we also have to build in. There's no way you can tackle one side and not tackle the other side. The distribution system, the GSDP system, we have to also build that and make sure that it's working for us very well. So that's the answer to that one. If I will have something that will be a magic one in the prevention and of that's the second question he asked of what I think is the best in the approach to mitigate this thing. I think the best to me, because if it's just one I have to pick, then you have to start from how to empower the patients.
Yeah. So
if I'm going to just pick one, so how to empower the patients, and that will talk about enlightenment. That will talk about making them understand how to take decision by themselves and how to know which one is right and all that. So the end users have to be taught. If I'm to use a magic one, that's the one I will invest more in, because all the other systems, one depend on the other, one also they work together. But this one is the last line of it, and we have to work with that. Okay, so what's missing, that to Taufik's question now, what's missing in current technologies? Personally, I've had a lot of presentations on different technologies. Personally, that a lot of people have brought for me. Let's see how we can implement it. Let's see how we bring this in. And all of them sound very, very fantastic. All of them sound very fantastic from the point of the database that it creates and the footprints you're able to get from where the contributors are, and how it's going to help us law enforcement agents to actually be able to know the trends and all of that. All of them works for me, but the missing link, there's no system that will not have its own disadvantage. No system. Now, one of the thing that I think is the missing link, and I'm going to say this across all the presentations. If I'm going to look at all the presentations that have been done, that I personally have seen, the missing link to me is the extra cost that it adds to the product. So some of them already are very expensive to apply, and so that means that we are passing additional burden to the end users who we are already working on affordability for. If I'm going to say that, so if we can get a system that will be not that it won't work, we're not saying it should be free, but that will be very, very, the cost that will be passed on the medicine will be very, very minimal, that it will not be felt, since it's going to be a mass this thing that we produced. That is a missing link for me that I think everybody has to be. And I'm saying this from my experience as a regulator and as somebody who have seen a lot of presentations that have been brought in. We most times the marketing authorization holders do not want to pass any additional costs to already what they have on ground. They don't want to pass that additional cost. So if you can have something that is, if we are for the missing link, I think we have to look for a cheap process that will be able to deploy without passing a major additional cost to the message. So that's my answer for you. And then you talked about patient awareness. What's the importance of it? I just mentioned that earlier. I think it is time to empower the patients with the correct tools and all of that to be able to take the right decisions by themselves and make sure that they are in control of what they use, and they can vouch for what they use. I think, and that's where we have to do massive investment in education there. On definitions of WHO substandard and falsified, difference, and because of the different pathways that I needed to get to each of these. I'll just give a very simplistic answer there. I'm not saying this. I don't want to give any academic answer. I want to give a very simple, simple answer, and the reason is because on the field, you don't have the time for all of the academic work. Okay, what do we this differentiator goes there? But the basic thing that we need, if something is substandard, it means that it does not have the right quality ingredient that is needed for the delivery of the action. It might be the same product, it might be the same, and we've had issues like that. Some of our people will go to China. I like to use direct examples. Some of our people will go to China. Okay, paracetamol is 500 mg. You know that was supposed to be inside the paracetamol, 500 milligrams. And they will give you paracetamol all the same, but what are you? They put 250 milligrams there, or they put 300 milligrams there. That's substandard. It's not fake. Because if you run just a simple test of, we used to have a machine we used to use, just do identification test. If you do identification test, it's going to pass. If you do identification, is it paracetamol that is there? Is paracetamol. But is it the right quantity? It's not the right quantity. That's a simple this thing there. And for falsified, basically there's an intention from the beginning. You're falsifying something, there's a from the beginning that you are getting a product to be taken as what is not. And that's a deliberate thing from the beginning. So let's say, I also want to give a very vivid example so that we understand what we're talking about. Okay, so now I have an example that I dealt with recently. Now, somebody has a product, let's say XYZ product, for falsified now. Another person wants to present that product as if it is XYZ product, while actually it's not XYZ. That is pure falsification of that product. And so that's just a simple thing I want to give there. I don't want to go into academic rhetorics of the different pathways, but it's very easy. If we do that, we'll be able to get across to know the pathways to deal with them. And I agree with you that each of them requires a different pathway to actually deal with when we're talking about NRF. The last question about activities for affordability. Yes, we talk about affordability. We talk about this and all the things that we try to put in gives us a level. Every level of quality we want to build in, the systems we build in, what comes up at the end of the day is that the products get more expensive. That's what comes up at the end of the day. So now I understand your question saying, so what are we doing in the bar affordability? I think we need to talk more about it because it's one of the third legs for medicines. If you have effective, you have all of that, and then it's not affordable, there's nothing anybody can do about that. And for us in Africa, I think we should look for how to build systems where we can have quality and affordable medicines for our people. I really cannot say this is one thing that have to be done, but I think it's a conversation we have to start doing to make sure that these things are affordable for our people. Thank you.
Yeah. Thank you, Dr. Iluyomade. Really great points that you're making. But I'm going to add to your point about the substandard and falsification, the differences in intent, that one, there is an intent to deceive, and then the other one can happen as a result of many things going wrong, but it's not intentional. So it just so happens that I was part of the Africa group, Africa group team of negotiators that discussed this issue at the WHO at a global level when we were discussing, maybe going back to the question that one of the participants asked, if it were a global problem, what would we do differently? And one thing that was really striking for me in that conversation, there was one country in particular that was very, very averse to the idea of calling these products counterfeit. And their argument for that was that if you call these products counterfeit, there was a risk that you would have generic products which are, copy versions of original medications. They are as effective, they're equally good, being conflated or confused with, poor quality medicines. And I mean, for me, I find that, really problematic, because I think if we ignore the intent, the fact that somebody is deliberately doing something criminal with the intent to deceive, it really muddies the water in terms of dealing with that criminal element of what's being done. And it takes me back to a conversation I had yesterday with one of the community agents of change that Medicines for Africa is, working with right now. You said if you had a magic wand, you would empower patients. And we are actually doing that by creating this network. We have a massive contingent of young people all over Africa that we are hoping, if when they understand this problem, will become agents of change, sensitization of patients and communities. But back to this, it was a very interesting conversation because I say to him, so what about this, do you find interesting? What has motivated you to become part of these frontline youths? And he said, I'm from the Gambia and we had a tragic situation some years ago. So many children died. And I think in my community, we have a great need for understanding these issues because we have seen the impact, what happens when communities and patients and parents aren't aware of that. And I think that's such an important aspect of this, the criminal, because so many children died, our children. I don't think anyone has been held accountable. These kids died from a product that was coming from a company that was a known repeat offender. They had even been banned in some countries not to bring their product because they were known to be selling products that were dangerous and contaminated. And in the Gambia, this somehow, some things failed, many things failed, and we ended up with tens and tens of children and parents and families in that situation. So for me, this idea, this academic argument, it really, our hearts are breaking. We are burying children. And so it's not an academic question. These are real lives, real people. Let's call a spade a spade. It's counterfeit, it's criminal, it should be prosecuted. End of story. This economic argument that, well, if you then conflict generics with this, and we want to be making money out of these people who are really making products we know as regulators in the manufacturing country are not really doing a good job, but we let them go because they pay taxes and so forth. I just think as African nations, this is something we need to find a resounding, effective answer on. Because the cost is not academic, it's much too great. It's children's lives, it's families, and so forth. So just to put that out there. So that's my perspective to add to yours. And I think this has been a great conversation. I mean, Dr. Iluyomade, do you want to? Is there some points you want to make before we close? This has been a really exciting conversation. We are way over time, but I think people want to be here. I want to be here. I don't want to stop. There is so much for us to unpack here, but this is only the first of many conversations. It's why we made a series, because the issues are so deep and so challenging that we need to do a deep dive into them. And Dr. Iluyomade, I hope you will come back and we can have even more in-depth conversations. We will bring in more NRAs. We have support from our leaders, from MCAZ, BOMRA, and others. They've already given us people who should be coming here and having this conversation with us. So I want to take this moment to invite you back, because there's so much here that we can learn. And the youth, we have the frontline youth that are in the room. Thank you for coming. And I hope from our leader here who's there doing this real work, you see that there is a big job for you to play. What we're trying to put together is not an academic abstract thing. It's a real thing affecting families and communities. And we are counting on you to step forward as young leaders to help our leaders like the NRAs, like NAFDAC and others, to really try to find ways of solving this, playing your part as agents of change in communities. So you have a big job. Please take it seriously. And I hope that in the conversations we will have, you take all of these, the things you've learned here today into consideration. But Dr. Iluyomade, do you have any closing remarks before we close this conversation that no one wants to stop?
Thank you, Lenia. My closing remark is that these issues are real. They are real. They are a hidden problem, and I think it's a crisis. And I am happy that we are talking about them. We need to talk more. That's my closing decision. We need to talk more because the impact on the public health, on economy, and all of that is huge. So all of us have been able to join hands together and make sure that we form a formidable force until our voices are heard and right things are done and make Africa and the world, not just only Africa, because this problem is not only in Africa, it's not only an African problem, a safer place with medicines. That's my parting shot. Thank you.
Thank you, Dr. Iluyomade. I found your presentation, as did many of the people. They came in their numbers to hear you talk, and really we've learned a lot today from you. You said the crisis is no longer hidden. It's a full-blown crisis. It's visible. And the only thing is that it's so big, we really need to start investing to understand just how big, how deep, and how much it's impacting communities. But that it's impacting communities is not at all in doubt. It is affecting, of course, the formal, the informal market mostly. That's where the significant impact is. Which really means the poorest people in our communities, the most vulnerable, the people who are saving and scrimping just to be able to afford that medication for a sick child, are being robbed of that little they have by buying something that does not work because it has no active ingredient in it. And I mean, that is criminal. I cannot think of worse things than that. And so we need to really have this conversation. We need to find ways of preventing them from coming in the first place. And that means action in the communities, themselves, but also the things that regulators can do over and above what they are already doing. The collaborative processes that you talked about when you're receiving medications, what kind of agreements can you have with the source so that you can really make sure that as much as possible you minimize the opportunity for those things coming in. So great conversation. And I think in the next session, we will go deeper, breaking down this issue so that we can really start to think of ways. What are we not doing? What could we be doing? What else could we do to help this problem or to mitigate against this problem and find opportunities? So I think going out of this meeting, I encourage everybody to think about what else you could be doing, what more we could be doing together as members of our communities, as families, and so forth. So I look forward to continuing this conversation with all of you. And I would like to thank our esteemed speaker, Dr. Iluyomade, for a most illuminating inaugural conversation that really put us on a good path to have further conversation about this. I would like to thank our heads of NRAs, the ones that have really been supporting and facilitating for us to have these conversations. And we want to thank them, Professor Moji, Mr. Rukwata, and Dr. Tumi and others. Thank you for the support. We will continue to have this conversation. We want to play our part because we know that the solution does not lie only with our regulators, it's also with us as members of our communities. So thank you everyone for coming in your numbers, for asking and engaging in a great conversation. This webinar series will happen every 2 weeks from now. And we have a great case study coming, looking at medicines across 4 countries. And so we are going to be bringing in practitioners. It's going to be real. It's going just like you heard today. So thank you. And I look forward to the next conversation. Thank you.